Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation program brought to you by Ipsen Biopharmaceuticals. My name is Rain Bennett. I am your host, and I'm a filmmaker and writer that's been working with CCF for 10 years, folks, 10 years. We started back in 2011, and we are still going strong, and the work that we have done has evolved over that time. It started off, and it still is to an extent, producing videos, treatment-based videos, patient-centric videos, and now doing shows like this, all with the same mission in mind, which is to spread awareness, educate people on neuroendocrine tumors. We all know, and if you're tuning in and a regular on the show, you know how important it is for us to be educated on this disease because it's so unique. Each case is unique. It's rare. A lot of doctors, general physicians don't know a lot about it. So this is crucial. This is the work that we do, and we're proud to bring you this show every week. So if you are a regular on the show, let us know where you're from. You're probably already doing it. I'll check on Facebook. There we go. Canada is always in the house. I love to see that. And if you're new to the show, say hello to everybody. Part of what the second big part of this show, besides the information that our guests present, is the community that we've cultivated here. So say hello to everyone. They will welcome you with open arms. And a lot of the information you'll get from their shared experiences is just as important. So go ahead and embrace that community. We always want to thank our presenting sponsor, Ipsen Biopharmaceuticals, for their support of Luncheon with the Experts. And we have this disclaimer that we like to say before each program from them that says that the opinions expressed by the guest presenters, as well as the questions asked by you all, the audience at home, haven't been created or suggested by the sponsors of Luncheon with the Experts. And CCF doesn't endorse or promote any of the views, opinions, or information provided in the presentation. Audience members should not rely solely on the opinions or information expressed by the guest and should seek guidance and direction from their own medical advisors regarding any choices they make about their health or treatments. Okay, folks, I know that was a lot. That last line is the real takeaway. We're going to give you some good advice and hopefully answer a lot of your questions, but by no means do we know your specific case. So take those answers, take that advice back to your home team, which does know your case, and make the best plan and path moving forward for you. We all know that each case of this disease is unique, and therefore each path forward is unique as well. Very excited today to host Dr. Sean Cleary. How are you, Dr. Cleary? Thank you for joining us.
I'm great, Rain. Thanks so much for having me.
Absolutely, absolutely. Dr. Cleary told me that a few of his patients had seen our promotion this week and are excited to have him. And for those that don't know him, I think you'll be excited as well. Dr. Cleary, for those people who may not know who you are and what work you do, tell us a little bit about yourself, where you work, what do you do, and how I like to phrase it, the role that you fill in the neuroendocrine tumor community.
Sure. Thanks so much, Rain, and hello to everybody. Thanks so much. It's a real honor to be here today. Rain and I were just talking about what a tremendous community this is, and what a great group of patients they are that support each other and talk to each other. So, as way of introduction, I'm a liver, pancreas, and GI surgeon. The technical term is hepatobiliary surgical oncologist. I'm the chair of that department here at Mayo Clinic in Rochester, Minnesota. For our Canadian attendees, I am actually Canadian. I was born in Toronto and I practice in Toronto, and some people may know me from Toronto. I was at Toronto General Hospital, UHN, in Princess Margaret for about a decade before moving to Mayo Clinic in Rochester. So I do, I again practice in GI and pancreatic neuroendocrine tumors, both doing sort of GI resections, pancreas surgery, as well as a lot of liver surgery for carcinoids. We're lucky here at Mayo Clinic that we have a number of us that are very focused on neuroendocrine tumors. And so we have a really great team here. And so again, I'm here on behalf of the team, but also here to help as many. And again, true honor to be here and really great to reach out to the NET community because they're such a fantastic group of people.
Right on. Well, I know that we're going to get a lot of great questions, or you will get a lot of great questions, Dr. Cleary, today. We talk about PNETs and pancreatic nets often on the show, and obviously liver and GI as well. So I'm sure the questions will come flooding in. And folks, that is your cue. Go ahead and start sending them in. We're going to get to them in just a moment. Just know that if we don't get to your question, or you have follow-up questions, which often happen when you get an answer, you can reach back out to us here on the Facebook page. You can send a direct message. You can also go to carcinoid.org, Come back next week. We continue to have these so that you will get that information. And also the show, you can replay the show. It's going to live here on the Facebook page. You can always come back to it. Starting Monday, we'll republish it to YouTube for those who don't have Facebook. So you can always come back to this video and watch it. So just know that if things are moving fast for you, which sometimes they do, I urge you to rewatch it. And also that plenty more videos that we have out there. I think the real value, though, is being here and being a part of this interactive one-on-one session, getting this question across. So if you know someone who's around, go ahead and share this with them, tag them in the comments. Let's get as many people here as possible, because yes, there's tremendous value in watching the replay. But I think if you have a question that's been nagging you, or really something that you're trying to work through with your team that you can't solve, this is what the show is for. So tag them in the comments. And another ask that I have of you all at home, I ask this every week, so you're probably used to it by now. If you see a question in the sidebar there on the right of your screen that you also have, or you're interested in the answer to, just below the comment, there's an option that Facebook gives you to like it, love it. There's actually a bunch of emotions you can use. Doesn't matter. They all work the same for me. That upvotes that comment effectively. It shows me there's a demand for it. So if I'm scrolling through the hundreds of questions that we inevitably get, and I see, hey, 8 people have this question, well, that tells me, Rain, that's a question that's important to get across. So helps me do my job, which is to help you. So in essence, it is helping you. All right, let's go ahead and start sending in your questions. So Dr. Cleary, always like that. Well, first of all, how long, and if you said this in your bio, sorry, I missed it. How long have you been working with neuroendocrine tumors?
So I really, it's been a focus and a passion for me since I started practice. I've been in practice now about 14 years.
Okay.
Again, 10 in Toronto, Canada, and then 4.5 here at Mayo Clinic. So this is an area that really was kind of an area that not everybody was interested in focusing on. Again, it's sort of an uncommon tumor for the vast majority of people, but I'd say that, you know, one of the things is people say is, well, this is an uncommon tumor, right? And it's like, yeah, it's uncommon out there in the world, but you know, for us in our group, and whether it was Toronto or Mayo or a lot of places around the country, getting to a place where it is common because they see those patients all the time is really, I think, one of the key things. So I was just fortunate to be part of that team. You know, it's a challenging disease because there's lots we don't understand. Some people look at that as intimidating or dispiriting. I look at it as a challenge because we're always constantly learning. The information is evolving. We've made great progress in the last 14 years,
big time.
both figuring out what we know and what we don't know. We've got new treatments coming online. So I just view it as a really, vibrant place to practice. I love, you know, the patients are fantastic. You know, it's something where we look at it as a you know, longer term disease. So we're looking at kind of lifelong management. How, not just what are we going to do today, but what are we going to do over the next kind of months to years, hopefully. And it's really trying to build not only just understanding, but also hope. Let's say we have options, we have treatment, and here's what I could see things laying out with. Obviously, none of us can predict the future, but we want to sort of set out a plan for management that not just addresses the current needs, but just kind of keeps in mind the long range view.
You know, you use this word, you're passionate about this, and I find that that's, I don't, it's probably not fair for me to suggest that, you know, doctors in other fields or with other diseases aren't passionate, but I just think that passion exists in almost all of the experts that we have on the show. And I think that a lot of that comes from it being challenging. And you also mentioned that as well. But is there anything else that drives that passion for this disease specifically?
You know, I think your passion comes from the passion of the patients. And I think, you know, this is really, you know, patients want to know what their treatment options are. They want to sort of, you know, they don't want to look at this as something that's going to necessarily define them, but it's something that we're going to manage long term. And so I think it's just that sense of when they kind of get to you and all of a sudden you're saying, you know what, it's okay, we know about this, we see lots of patients like this. There's kind of that sense of relief, and then we develop partnerships, and they're long-term partnerships, you know, in terms of managing their disease and trying to figure out what's important to people, how they want to approach their disease. Do they want to be, super aggressive, or would they rather take an observational approach? And the nice thing is we can talk about options, and we have lots of options. And so that's always a great situation to be in, because it becomes very much a dialogue in terms of how are we as a group, and that into, as a team, patient and the physicians and the surgeons, how are we going to approach this disease, with obviously the patient being the one who's going to be sort of the captain of the team and driving those decisions. But it really is, how are we going to manage this? And so there's uncertainty, and some people are afraid of uncertainty, and some people are uncomfortable with it. I think we just have to, kind of embrace the uncertainty, but also know that if we take a gradual approach, and we stay involved, and we stay engaged, and we communicate with each other, we'll navigate the uncertainty together.
I love that. This word relief that you said, we see that on the show. People that might have been struggling with this, there's a disease that they don't know much about. There's a lot of confusion and question marks. And I see every week that answers are delivered where people have that moment. So I really like that, that you mentioned that. And I know it's got to be that way when a patient finds someone who says, like you did, hey, we know about this, here are some options, so I feel that relief as well. Speaking of that relief, let's start answering some of these questions. They are already rolling in, so we're going to start taking some from the audience. First one up is Beth. Beth says, so how often do neuroendocrine patients have the gallbladder removed, especially when they are on sandostatin and lanreotide?
Right. Beth, great question. Thanks so much for your question, as it's one that we deal with a lot of the time, and that is really the acknowledgement that sandostatin is a great drug. We know that patients hopefully are going to be on it for a long period of time. We have great data to support its use. And like anything, it has its pros and its cons. And one of the cons is that it doesn't get along with your gallbladder. What sandostatin does is it sort of causes the gallbladder to become less active. And so doesn't contract as often, because it normally contracts to deliver bile into your intestine when you have a meal. So sandostatin kind of makes it less active, and so therefore the bile can kind of accumulate in your gallbladder. And when it sort of sits there, it's kind of like water. If it's running and it's moving, everything's fine. But when it stagnates or it doesn't move, then the bile inside the gallbladder can cause stones. It can cause irritation and inflammation. And so what we don't want is it to become a problem in the future that's going to interrupt your treatment. So I think our general approach is that if you're going for surgery for a neuroendocrine tumor, and if we think that there's a likelihood that you're going to need to be on sandostatin either after the operation or in the longer term, removing the gallbladder, if it's reasonable to do so, is not an unreasonable thing to consider. So as long as it's not terribly risky, as long as it's not going to make it a significantly more risky operation, then we generally recommend it, because again, it's something that we don't want to have to go back later and do if we run into problems. We've not been really in the situation where we've been suggesting to people that they get their gallbladder out before starting sandostatin therapy if they haven't had any problems with their gallbladder. In other words, the gallbladder doesn't need to come out before you start sandostatin therapy. That being said, if your gallbladder's been kind of grumbling along and bothering you a little bit, that won't get better on sandostatin. So if it is bothering you, it's probably reasonable to have it removed before you start sandostatin, just because it's likely that those problems are going to get worse. So Beth, I hope that answered your question, but it is one that comes up frequently, because sometimes when we're doing surgery or planning an operation, I say, oh yeah, and your gallbladder is going to be removed as part of it. And it's a natural, well, okay, why? And that's kind of the thought process.
Got it. Thank you so much. And thanks, Beth, for your question. And this goes for Beth and anyone else. If you're still online as the show goes on and an answer to your question creates a follow-up question, please feel free to go ahead and ask that as well. We'll try to get to it. Next question from Jim. Jim says, I've had 75% of my pancreas resected, the tail end. Now the focus for the past few years has been my liver. As a surgeon with a patient with a patient with 25% of the pancreas remaining. What would you do? What would you be doing to follow up to make sure there's no recurrence in the pancreas? I do get regular scans on my liver and abdomen, but knowing how difficult it is to get good imaging on the pancreas, what would your follow-up plan be there specifically?
Right. A great question, Jim. And so, yeah, so there certainly, you've got 25% of your pancreas, and obviously the concern is that we can get new lesions occurring in the pancreas. So you need it as part of your kind of plan for what we call surveillance. So we're keeping an eye on things. For the most part, CT scans and MRIs that you're probably undergoing to keep an eye on your liver are probably doing a pretty good job keeping an eye on your pancreas as well. Those scans usually need to be done with contrast or dye, but the liver and pancreas are quite close to each other. They generally, sometimes when we order scans for the pancreas or scans for the liver, they're very, very similar in the way that they're done. So I suspect that your team in following your liver is also following your pancreas relatively closely. If there's a suspicion that there's something unclear in your pancreas or they're worried about something, there's other ways we can look at your pancreas. Again, if there's a suspicion, and that can include doing an ultrasound through an endoscope. So they call it an endoscopic ultrasound, which can get a really close look at your pancreas. Or sometimes if a CT is uncertain, we'll follow it up with an MRI. And sometimes if an MRI is uncertain, we'll follow it up with a CT scan. But most likely the tests that you're having done to follow your liver are probably also getting pretty good pictures of your pancreas as well.
Got it. Got it. Thanks so much for your question. Next question from Gene. Gene says, I have a high-grade NET, SI primary and removed, and I'm on a phenotor 10 milligrams for 10 months stable. I just got a mild case of left lower lobe pneumonia, and I've never had any kind of lung infection before. Has this made me more susceptible to lung infections? And is there anything I can do to decrease this susceptibility?
Sure. So, a phenotor is a kinase inhibitor. So it's a form of treatment. And while it doesn't have the same immune effects that kind of standard chemotherapy does, I think there is at least some acknowledgement that it does have some implications for immune system. We did see in the trials that established a phenotor as one of those things, a rate of infections. And so I think that, is it due to the phenotor? Well, we don't know that. Could it have contributed? Yes, certainly, people can get pneumonias even without being on treatment or even without neuroendocrine tumors. People can get pneumonias just walking around. And so I think the main thing is to be very aware of symptoms. Try and make sure that if you're concerned about something, you reach out to your doctor or your oncologist early, because you don't want those things to fester and interrupt your treatment. But I think it's just a matter of being very vigilant in terms of any kind of concerns you might have, but also symptoms you might be having.
Got it. Got it. Another question from Gene. Gene says, can anything surgically be done for carcinomatosis of the abdominal cavity and pelvic cavity?
Sure. Great question, Gene. So peritoneal disease, which is like deposits of the tumor on what I call the lining of the abdomen, which is your abdomen is sort of like a drum that has the organs inside it. And we're talking about the lining of that drum. It's a challenging problem because it means that the tumor has spread beyond the original site. And it's one of these things where what we can see in terms of the level of disease is often a lot less than what's actually there at a microscopic level. So I use the analogy that it's kind of like salt in your food. If you can see a little bit of salt in your food, it's probably there's more there than we realize. There are situations where we treat peritoneal disease in other cancers, and that particularly is used both removing the tumors and sometimes using chemotherapy directly inside the abdomen, called a procedure called HIPEC. We don't do that typically for neuroendocrine tumors, just because we don't have very good chemotherapy that works in that context. There are probably some clinical trials that may be involved in that, and so I think you'd be worth asking about that. We don't have anything that I don't know of any trials that are open to that, but that's pretty aggressive and kind of non-standard. So outside of a clinical trial, I'd probably be kind of hesitant, but I want to ask a lot of questions in terms of talking to your physicians and your surgeons about the risks and benefits, because we don't have very good evidence of benefits of those kind of operations in neuroendocrine tumors.
Got it. Thank you. Next question from Amanda. Amanda says, how large does a tumor need to be seen on a scan? Nothing. I'm seeing nothing on a scan, but I'm having terrible carcinoid syndrome and had terrible results from the NET test.
Okay, yeah. So great question, and the answer depends on what the test is. Mm-hmm. And so what I think for the most part on a CT scan, we're talking about something in the 5 millimeter range to, definitely a centimeter. Same kind of for MRI. For dotatate imaging, and it's probably a little bit larger just because the granularity of the dotatate imaging is not as fine. So you might be in this kind of 1 centimeter range. And for the octreotide scans, it's probably around a centimeter or so. The NET test, I think if they're talking about the kind of commercially available NET test, well, that just kind of determines the sort of risks involved. And so I don't know that we have, great data from the NET test to say that absolutely there's something happening, but we just know that if that shows a high risk of recurrence, that we just need to be vigilant and watch for things. But it's hard to treat what we can't see, but at least with the current imaging, we're able to see things that are kind of in the millimeter range with most tests, particularly if we combine tests. So often one test is not always the answer. So just a CT scan or just an MRI or just a dotatate scan, but these tests are complementary. So sometimes your team may order multiple different tests, because bringing them together, you can get better information and it helps the radiologist interpret it better.
Got it. Got it. Well, another thing Amanda is experiencing is carcinoid syndrome, or the symptoms of carcinoid syndrome. And so she has a follow-up question. Does a tumor necessarily need to be in the liver to experience carcinoid syndrome? And if not, where can tumors be to generate those symptoms?
Sure. Great question. And so the reason why the liver is sort of an important component here is because the liver filters out or eliminates a lot of the serotonin that's being produced by carcinoid tumors if the blood is flowing from the intestines or the pancreas or any of the organs within the abdomen up to the liver. So the liver is a great job of filtering it before it gets to the rest of the body. So we can see carcinoid syndrome in patients that don't have obvious liver metastases when the blood can get to you, the rest of your circulation, without having to go through your liver. So that would certainly involve the lungs. So the lungs, obviously, the serotonin gets directly into the bloodstream. And also we know that carcinoid tumors in places like the rectum or high in the stomach or the esophagus can also get out into the general circulation without being filtered by the liver per se. Rarely, but occasionally, we've seen patients where they have very small carcinoid liver metastases that kind of are allowing the serotonin to get out into the circulation. That's pretty uncommon, but I have seen that a couple times where it's kind of below the level of detection, which is probably where some of the levels of detection questions came from.
All right, moving on, folks. Next question from Linda. Okay, so we've talked a little bit about scans. Linda has a question, and it's an opinion question. What's your opinion on the new PET copper 64 versus gallium 68?
I don't have a strong opinion in that regard. I've not seen a lot of the data around copper 64. Really, the thing to remember is that's the radioactive isotope that is used, that's connected to the dotatate or the octreotide. And so really, it's not so much what's binding to the tumors, but it's what the machine is detecting. So sometimes the radioisotope that they use is a little bit related to how it's produced. There's some evidence that maybe some isotopes are better detected by some machines than others, but I don't have a specific opinion in that regard, other than if there's something that's better than gallium-68, I think we'd all love to see it. But gallium-68 is kind of what's being used. There may be trials going on at your local center, and so I'm all ears and interested in the results of those trials. And it's a pitch to also all of our patients that we're all trying to learn more about this disease. So specific studies and questions and trials are important for us to do in our community, because it helps us gain knowledge. And so if there's a trial out there that you've heard about copper 64, it's good to participate in those trials if they make sense to the patients and make sense to your team.
Got it. Thanks, Linda. Folks, if you just joined us recently or joined us a little bit late, this is Luncheon with the Experts, at Carcinoid Cancer Foundation program. Today, we're here with Dr. Sean Cleary. So I hope you're getting some great information. Keep those questions coming. As always, the questions are awesome. Next one coming up from Teresa. Teresa says, most recently I had a gallium-68 PET scan and a mass showed on my left ovary/uterus. An MRI was done and 3 fibroids were found. Is it safe to assume that the spots are not and will not become nets?
Okay. Yeah. So I think, listen, it's very difficult to make specific sort of comments about that without having been able to see the scans, without being able to talk to the radiologist. And so I would say in a general sense that yes, there are occasionally things that light up on scans that may not be neuroendocrine tumors. We know that things like meningiomas light up and certain things in your thyroid can light up. But I think the most important thing is that your physician has talked to the radiologists, that they've had an opportunity to review them at a tumor board round that deals with carcinoid tumors, and to see what everybody thinks of that. Because again, there's a lot of nuance there in terms of what it looks like, how bright it is on the scan, what the organ looks like without the radioactive dye, so what it looks like on an MRI or a CT scan. And so I think all you want to do is make sure that your team's having those discussions, and then they can provide you with some advice, acknowledging that imaging isn't perfect. And no one can predict the future, and no one can give you, these are these kind of situations where it's rare that we can be 100% certain or 0% certain, and there's a lot of gray. And so I think it's just important to talk to your team, ask them about those discussions, make sure your team's discussing it internally with the various experts in their center.
Got it. Thanks, Teresa. Hopefully that helped. Okay, next question from Nancy. Nancy says, I had a low-grade net removed from my small intestine and 3 liver mets in late May. I had a chest, abdomen, pelvis CT scans in September, and I've had dotatate, PET CT, and MRIs later this month. After the immediate post of period, what is the standard care for scan follow-up?
So great question. And first of all, I hope you're doing well after your surgery. Sounds like it was a good undertaking. And I'm again, I hope you've recovered well. I don't know that we have real consensus in the community about what appropriate follow-up is, but generally it involves, I think if you look at the accepted NCCN guidelines, that is standard CT scans, the frequency of which I think is listed as every 6 months, but I know many of us are doing that just a little bit more often. And how we use dotatate imaging in follow-up is really not totally certain. I think many of us are doing it because we think it's the right thing to do, and we're using it, but I don't know that we've got enough experience with dotatate scanning in the post-operative period to really have specific recommendations in that regard. That being said, I think we do know that particularly after an operation such as yours, we have data to show that we probably need to follow you for a while. So I think in many other cancers, kind of oncologists or surgeons will follow you for about 5 years. And then at 5 years, they kind of say things are great. We've done some data, Simran Singh in Toronto, and it was the lead author on a paper that just shows that in carcinoid tumors, we probably need to keep an eye on things for longer, whether that's 10 years or longer. Again, just because if something comes back, we want to detect it early, and we want to detect it at a time when your team has options to offer you. So just to say, the follow-up is probably at least every 6 months, maybe a little bit more frequent in the early period afterwards, but should probably continue to at least 10 years and possibly beyond.
Got it. Thanks so much. Okay, question from Ruby. Ruby has some concerns. Ruby says, I have diabetes, in heart failure and carcinoid syndrome. The question is, would you recommend getting the booster shot? And I think there's a bigger question there that comes up frequently, Dr. Cleary, here on the show, of the vaccines in general,
Sure.
especially when you're dealing with the net. So specifically, Ruby's asking about the booster shot with her concerns, but we have a bigger question there too. So
Yeah, and this is one that comes up in flu season because
sure.
everyone wants to know if they should get their flu shot.
Yep.
And I think the most important statement is it's a conversation that you should have with your physicians, your team, to make sure that they're involved in this decision. And it's a great question.
Mhm.
For the most part, it again depends a little bit on what sort of treatment you're getting, and that patients who are on active chemotherapy that has an influence on their immune system, or if they're on immunotherapy, which is not widely used in neuroendocrine tumor, there are specific recommendations around immunization in people who are on treatment. In terms of what you've described in terms of your health concerns and other things, there's nothing listed there that would be what I'd call an absolute contraindication to receiving any immunization, whether that's the flu or a booster for COVID. But we also acknowledge as patients with carcinoid and other health concerns that those are those underlying health conditions that increase our risk, not just our risk of catching diseases, but the impact of that disease. And you don't want a preventable disease interrupting your cancer treatment, because that's obviously what's most important. So above all, it's a discussion with your team. But by all means, I'm an advocate of vaccinations, because I think, again, the last thing anybody needs is to get the flu or to get COVID or to get a preventable disease while they're tackling their carcinoid tumor. So great question, and one that's comes up all the time.
All the time. All right, moving along, folks, and the show is moving along as well. Great questions today, as always. I told Dr. Cleary that you all would be bringing them today. Susan says, when metastasis spreads to spine or other bones, do you recommend patients take a bone strengthener? And if so, is the purpose to prevent bones from fracturing, or is the purpose to help halt progression?
Right, great question. So the issue of the bone metastases is an interesting one, because as we're doing more scans and we're doing the gallium-68 scans, the dotatate scans, we're seeing more of these. And I think that we're seeing them more nowadays, but I don't think they're any more common in patients. I just think that for a lot of times, these things were relatively indolent. In other words, they didn't bother people, and and so we're just seeing them more often. But very often for many patients, they're just they don't bother them to a great extent. For the most part, calcium supplementation and bone strengthening regimens, sort of the osteoporosis medications, I don't think we have data to suggest that they affect the tumors per se, unless there's, outside of the context of a clinical trial. That being said, as we get older, our bone health is something that just deteriorates over time. It deteriorates more in women than men. And so while we know that those lesions are there, we need to look after, the overall bone health, because that may fend off other bone problems such as that are commonly associated with osteoporosis. So I'm not aware of any data to say that it has any direct effects on the tumor, but I think it's probably more commonly around supporting overall bone health and making sure that we maintain our bone density, particularly if we're going through treatments. Age and our sex can influence our bone density, but so can many of the treatments that we're having. So those are kind of things that are all probably part of the consideration.
Got it. Thanks for your question, Susan. Next one up from Rebecca. Rebecca says, if I'm going into full-blown carcinoid syndrome, 2 weeks post-treatment, sandostatin LAR, is my cancer growing, or do I need to get treatment earlier? I'm having a PET scan done in December, but these past weeks have been exhausting. I'm sorry to hear that, Rebecca.
Yeah, I'm sorry to hear that as well. So if you're getting, symptoms of carcinoid tumor and you're on sandostatin, there's a couple options. And again, it depends on where you are in your treatment with your provider. Very often, many patients will require an escalating doses of sandostatin to help control their carcinoid syndrome. And sometimes just increasing the dose will get you better control. There are sometimes, once we've kind of hit a maximum dose of that monthly injection, sometimes we can shorten the interval between doses, whether that's instead of every 4 weeks, every 3 weeks, and there are certainly patients that are even every 2 weeks. If sandostatin isn't controlling your carcinoid syndrome symptoms, then you may need to talk to your providers about other treatment modalities to help manage those symptoms and control them, whether that is surgery, whether that is embolization, whether that is chemotherapy. There's a whole host of options that you should discuss with your provider. That being said, every time you have carcinoid symptoms, that's not only having an effect in terms of your overall well-being, you're flushing, you're having diarrhea, you could be getting dehydrated. It's damaging to the valves on the right side of your heart. And so I think that that's something to address with your local team sooner rather than later. And I wouldn't wait a kind of a month or two to kind of just put up with it, especially if it's dragging on you. I think that's something you want to reach out to your doctor and say, listen, this isn't perfect. It's not going well. What else do we have? And then we could talk about increasing the dose, changing the scheduling, or other treatment options.
Got it. Thank you, Rebecca. Philip says, I had surgery in April and now I'm going in for Y90. I have carcinoid tumors and carcinoid syndrome. Should I consider getting an echocardiogram for carcinoid heart disease?
Well, I think that the short answer is, I think, yes, it's always good, I think, to have to keep an eye on your heart if you're having carcinoid symptoms, because again, this is one of those things where you won't really develop symptoms of the heart valve problems until things are really far gone. And so I always think that it's something that we probably underappreciate. So I think it's not a bad idea to get an echocardiogram, even just as a baseline, but also we tend to advocate doing it semi-periodically, because if we don't want the heart valve problem to get away from us and then need to get to a point of needing heart surgery to do that. For the Y90 treatment, I don't know that it's that important to do before the Y90 treatment or after, just because the Y90 and your heart are, I don't know that it would necessarily one would necessarily interfere with the other. Y90 is out there, it's an option. There's not a lot of data behind it, so I just think you want to make sure that it's part of a good discussion with your treatment team in terms of that, make sure that that's the right option for you.
Got it. Hey, thanks, Philip. I appreciate your question. Moving along, folks, we got just about 20 minutes left. Rose says, I had debulking surgery 6 months ago, and there was no metastasis to the liver, but tumors had spread to the ovaries. They were removed, and mesentery. Since surgery, I do not experience flushing, but blood tests indicate that the level of serotonin is increasing. Recent MRIs and CAT scans do not reflect any tumors. What could be causing this increase in serotonin?
Right. So one of the challenges in this disease is even when we do aggressive surgeries like this, like you've had, and I hope that you're doing well after your surgery. I think what we know from our experience is that while we may have removed everything that we can see, there may be, small microscopic deposits of tumor somewhere, whether that's in your liver or elsewhere. And so that's why, unfortunately, those kind of surgeries are rarely what we call curative. But what we're trying to do is kind of turn back the clock and buy us some time, off of, without symptoms. If the serotonin levels are starting to slowly creep up and we don't see anything on the scan, then it's just important to be talking with your local oncologist or your local neuroendocrine specialist, because that there may be a role to talk about things like sandostatin if that level, the serotonin level gets to a high enough that it starts to become an issue. So yes, while again, much like I think the previous question, sometimes there's situations where we can't see anything, but we know that at a microscopic level, there are cells producing serotonin. We sometimes just need to be aware of that and discuss what the parameters are for monitoring it and what the triggers would be to start to treat it with something like like octreotide.
Mm-hmm. Thanks, Dr. Cleary, and thanks, Ruby, for your question. I also want to say thanks to Rebecca. I see that you were tagging a bunch of people earlier, trying to get them into the show. So you, my friend, as the kids on TikTok say, understood the assignment. Thank you. Next question from Allison. Allison says, for patients, and this question I see a lot, for patients with tumors that do not have receptors and do not light up on the new scans, which method of imaging is best for pancreas, liver, and spleen? So don't have receptors and they don't light up on scans.
Right. So if we don't have the option of the receptor studies, and that's the dotatate scans or the octreotide scans, then we tend to focus on less neuroendocrine specific imaging like CT scans and MRIs. And those are, people always ask me which one's better. And I think we talked about this before. I think they're complementary. It doesn't mean that you need both per se, but I think you want to talk to your team and see which of the imaging modalities they're most comfortable with, and what's widely available. I don't have a specific opinion that one's better than the other, but without the receptor-based imaging, we just tend to focus on what I call the dye-enhanced or contrast-enhanced imaging with CT or MRI. Is the most common.
All right. Thanks, Allison, for that question. Next up, Julie, what is the current thinking for NED, no evidence of disease patients, grade 1, stage 4, small bowel, for long-term somatostatin analog shots versus the watch and test frequently approach?
Great question.
Okay.
And I think that this is something that we talk about all the time. And I would say that there's not consensus opinion among a lot of the experts. So even then among the non-experts, there's going to be even less consensus. We have data to show that octreotide or sandostatin are able to delay progression, which is growth or appearance of new lesions. And we have that from the various studies. When to start that was not well addressed in those studies. So most of those patients had obvious disease, visible disease. And in one of the studies, they had to have growing disease. So we don't have great information to say when to start octreotide or sandostatin. Based on the trials, we'd say it's not unreasonable to start when you see disease or see growth. At the same time, there's an expectation that, maybe we can do better by starting it earlier. We don't have the answer to that. And that's why I think it's a conversation to have with your local doctors, but it's a great question. We spend a lot of time debating that, not only at meetings, but also even amongst ourselves when we're talking to patients.
Got it. Interesting question. I don't think I've seen before from Kimmy, also dealing with tumors with receptors. Can you have some tumors with receptors and some without at the same time, as far as what is showing up on scans?
Also, great question. So we know that as tumors spread, they can change, and that can, because as the tumors evolve and as time goes by, tumors can develop new mutations in their DNA, and that can change a little bit of the characteristics. We know that because sometimes, so patients, like some of the previous people had said, have had multiple tumors resected in the same operation, and we can see that some of those tumors are kind of grade 1, while others from the same patient at the same time and in the same similar location can be G2. So we know that there can be some differences between the tumors within a person. Can that manifest so much that some are receptor avid and some are not? It's not common, but it can be seen. It's not common, but it can be seen. What we want to be certain of is that they look like, then that's where we get these complementary imaging technologies, where we're not just going to look at the receptor-based therapy with that dotatate or octreotide, but we're also going to do a CT scan or an MRI, and bringing those together, we can see that, yes, this looks like a neuroendocrine tumor on CT or MRI, but just doesn't light up on the octreotide or dotatate imaging. So it is possible.
Got it. Hey, thanks, Kimmy. Next question from Julie. Are you aware of any issues regarding availability of sandostatin due to supply chain issues?
Well, I guess the short answer is no, I have not heard that, but sandostatin is, just like many other drugs, and it's like a whole lot of other things that we're going through right now, that supply chains have been disrupted. And so we're going to have a hard time getting holiday gifts for people, and we may have a hard time, getting shipments of medication. So I don't know anything specific. I haven't heard anything specific about sandostatin, but sometimes these issues can be regional, sometimes they can be national, and it's distressing and problematic for patients and physicians. So I hope that that's not a problem that's affecting many people out there, but I know that everybody involved, from the doctors to the companies to everybody involved, is probably trying to figure out their very best to address it as best they can.
Yeah, it's an interesting question, Julie. It's going to be interesting to watch how this all develops and impacts many aspects of our lives, and is currently impacting many aspects of our lives. So I hadn't honestly thought about that yet. Okay, next question. Let's see. So we were talking earlier, Dr. Cleary, about some of the challenges of this disease, and you had mentioned some new treatments coming up. I know that in the 10 years that I've worked with CCF on the disease, how much has become available, like how much better we are at diagnosing this and treating this disease. And you had mentioned some of the newer treatments. What are some of those new treatments that you're excited about, things that might be coming down the pipeline in the next coming years? What are some of these new developments that are really helping you all do your jobs better, more effectively?
Yeah, great question. So, I think that one of the things that I remark on is, when we, about 10 years ago, we might have had one clinical trial or two clinical trials available at any one place for neuroendocrine tumors. And now we're seeing like 5, 6, 7 trials available. So that just tells me that there's a lot of interest, excitement, and enthusiasm around neuroendocrine tumors that wasn't there 10 years ago. And as we start to see some of the new therapies coming on board, We're hopeful. Again, we don't know until we've finished the studies whether they work or not. But I think we've seen great advances in imaging technology with dotatate scans. And again, we've talked about gallium and copper and other markers. Some of the treatment regimens, so capecitabine and temozolomide for pancreatic neuroendocrine tumors. We've seen the phenotor studies that that have come out in the last 5 or 10 years, and now PRRT has come on board in the last kind of 3 to 4 years, and so those are expanding what we have in our repertoire. It's expanding what we have in the cupboard to be able to treat these tumors. And while I don't know that there are any home runs per se that I've seen in the near future, the more things we have available to us, the more we can work with patients over the longer term. And that's what I talked about, that sort of like that long-term management. So we're going to start with this, and then if that doesn't work, we'd have this, or we have option B or option C or option D. 10 years ago, we had option A, and we might have had an option B, but now we've gotten much others. And because this is a disease where hopefully in many patients, we're going to battle this for an extended period of time, just having more kind of arrows in the quiver or more tools in our toolkit to be able to address this really just kind of makes this exciting. So I don't know that we're going to have the kind of the home run that we're going to, get rid of this disease in the near future. I hope we do. We're all looking, but we're just getting more and more things coming online that are expanding our repertoire. Because again, just the drug companies and a lot of this funding agencies for studies just weren't all that interested in this disease 10 years ago. And now there's a lot of enthusiasm and a lot of interest.
That more tools in the toolkit concept is so important with this. And I understand what you're saying, but you said it so you made it so simple to understand looking back, 10 years plus. When you have a disease that each case is completely unique and can go on its unique path, to have only one tool in that toolkit is like, that's problematic. So, I mean, this is a big leaps that we've had adding new tools to that 100%. Folks, we got just shy of 10 minutes left. So let's keep asking some questions from Rosina. If a CT scan is done in a hospital that doesn't deal with neuroendocrine cancer, how do we know that they know what they are looking at in the radiology department?
So that's a great question, and it's certainly something that can be a challenge. So it's very there's the CT scan that's the machine, and the machine does the studies, and to a certain extent, the ability to pick up neuroendocrine tumors has nothing to do very much with the machine, but it's how we program the scans. In other words, how they time the dye that goes in. So that's one component. And then the other component is who's looking at the scan. So does the radiologist have a lot of experience looking at the pancreas and looking at the liver? One of the things that is nice about scans is that they're portable and you own your scan. So if you have any questions about your scan and not confident with the way in which it's being done or being read, you can get that CT scan or MRI or dotatate scan or octreotide scan, sent to another institution and get them to look at it and see what their radiologists think of it. Or you can, put it on a disc and take it with you to an appointment. There's various options for getting what we call radiologic second opinions. And many centers like the one I work in at Mayo will take, people, scans from elsewhere and have their radiologist look at it. It's obviously something that requires a bit of work, and it's not for many institutions, it'll come at a slight cost, and it'll be up to you whether your insurance plan covers it. But that's certainly an option, and that you can get another radiologist who might spend a little bit more time of their day looking at a pancreas or liver or intestine, or has a little bit more experience looking for neuroendocrine tumors to take a look at it. But at least start there, and then they can say, listen, I'm not happy with the way this was done, and so I would recommend having the scan done a different way.
Mhm.
Or they can say, yeah, this is a really good scan, and I see this, or I don't see this, or I agree with the local opinion or not local opinion. That's an option that's out there.
Got it. Next question from Dorothy. Dorothy says, my primary was in small intestine and that metastasized to an ovary. When I get my 6-month CT scans, my insurance company always denies lung scans and only approves abdomen or abdominal and pelvic scans. How hard should I pursue fighting with the insurance company about this? Are they right that I should ignore the lungs?
Great question. And I generally try and do a disclaimer that I can't explain the behavior of insurance companies. But what I would say is that, in insurance companies have kind of rules of what they will and won't do. And sometimes unusual tumors or rare tumors like carcinoid tumors fall through the cracks of those rules, and that, the rules are made to apply to breast cancer and colon cancer and pancreas cancer, adenocarcinoma, things that are more common. So sometimes we have to be strong advocates in the situation of rare diseases. And so I think that's something where, yes, if you think it's important, and if more, especially if your provider and you think it's important, you have to push back. Remember, you're paying your premiums and to them. And so very often, sometimes it's just a simple phone call to them, to either between your provider and the insurance company, to say, listen, the policy that you're referring to just doesn't mesh with this situation. And so, they'll try and come to a middle ground or try and make a decision. But you don't have to take the first decision of the insurance company as kind of the final decision. That sometimes we have to explain the situation or explain the context of the decision. So if your provider thinks that a lung scan is required or appropriate in that case, it's important for them to kind of go to bat for you with the insurance company to say, no, this really is not superfluous. It's not just kind of adding tests for test's sake. This is important. And hopefully your insurance company is receptive to that. But it's a problem we deal with neuroendocrine tumors all the time, because it's not a common disease, that, the rules are made for other diseases that don't necessarily apply to carcinoid. So that's why we got to advocate with your insurance companies, advocate with your physicians, and advocate for the groups that make these guidelines. So.
Got it. And hey, Dorothy, thanks for your question. I will say this applies to you and everyone else. As I mentioned at the beginning of the program, I've been working with CCF and creating video content for a long, long time. And we've been doing the show for over a year now. So we probably have a video out there for any topic that you can think about. And specifically, about a year ago on the show, we featured Laurie Todd, who's known as the insurance warrior in the net community. So Laurie Todd, and you can look that up. And that whole episode was about appealing insurance claims or denied insurance claims. So hopefully that could help. And that, again, that goes to anybody, whatever your certain area is that you're looking into, we've probably got a video for it. So just look at the database. Probably got time for one more question, folks. Let's see here. Okay, Barbara said, I had a question. I had a small tumor removed from the ileum in 2012, small bowel resection, no metastasis to lymph nodes or liver as far as they could see. There's now a small spot doctors are watching on my liver. Could this be new cancer or spread from a small bowel net, if that makes sense?
Yep. Yeah, it does. And this is a good common question. Neuroendocrine tumors, if it's in the liver, the question is always, did this start in the liver or did it spread from somewhere else? It's a difficult problem because, again, there are lots of patients where we see spots in the liver, but we don't see where the spot started from. And so that's led to the question of whether spots can start in the liver itself. We do see neuroendocrine cells in the liver, like non-cancerous neuroendocrine tumor cells, but they're pretty uncommon. So the statistics would say it most likely came from somewhere else. So the important question for, I think, you and your providers is this something that was spread from the tumor that was taken out in 2012 and it's just been kind of hanging out and there, and now it's starting to grow a little bit. But the other possibility is, could there be a new tumor somewhere else in the intestine? Because we know that people who have small bowel carcinoids can have multiple lesions or develop new lesions over their lifetime. And that's why we keep on with the follow-up more than 10 years. So we won't know the answer to that per se. It could be either. Just kind of statistics wise, it probably came from somewhere else in the intestine. Whether that was the original one or a new one, it will be difficult to determine, but it should just lead to more investigations and sort of looking at that, at least considering those options.
Got it. Thank you very much, folks. That's going to be our show for today, but I want to end on this final comment from Marty, who says, I love Dr. Cleary's answers. So direct and clear and to the point. Thank you so much. And I like that too, clarity above all else. So Dr. Cleary, I appreciate your time so much. Thank you for being here and sharing that time with us.
Well, thank you so much for having me again. As I said, it's an honor. It's just an honor to be involved in the carcinoid world, both as a treatment and being able to do this, because the patients are so passionate. They want answers. It's a great group. And again, thank you to everyone who came in today. It just shows your dedication to your health and dedication to this disease and dedication to supporting each other. So thank you so much. Thank you to the foundation for everything they do. And again, it's been a lot of fun for me. The questions are fantastic. They're very insightful. And they keep us on our toes. So keep keeping us on our toes, because it means the more questions we ask, hopefully we'll find some answers.
Absolutely. And I have to agree about the community who has welcomed me with open arms, who is not a doctor and not a patient. And it's one of the highlights of my career to be involved with this community. I'm very proud of the work that we do here. And that is a big thanks to you all as well, the community, for being here and being on the show and showing up every week. So as always, we hope the program helped answer some of your questions. And again, I'll reiterate, reach out to Carcinoid Cancer Foundation at carcinoid.org or here on their Facebook page if you have follow-up questions, and we'll be back next week. Obviously, we're getting close to some holidays, so we'll have some weeks off, but we're here every week, folks, and we won't be going anywhere anytime soon. Thanks, as always, to our presenting sponsor, Ipsen Biopharmaceuticals. Without them, this program wouldn't be possible. And finally, my name is Rain Bennett. I am your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay safe, everybody.
Thanks so much, everyone.